started. Let me start recording. There we go. So one more time, good afternoon, everybody, and thank you for taking the opportunity to join us today for our webinar on acting on social determinants of health screening data to address barriers to health, today on July the 28th. So as an attendee today on today's webinar, you'll be able to use certain features. The first feature is going to be the audio. If you click on the mute and unmute button, you will be able, you will allow yourself to use a microphone. However, to minimize background noise during the presentation, all attendees are muted upon entry. If you click on the up arrow on the right-hand side of the mute and unmute button, that allows you to choose specific audio settings for your microphone and speaker setting system. The next feature is going to be your question and answer feature. During the presentation, you may ask questions. Simply click on the Q&A and type your question into the free text field. The moderators, organizers, and guest speakers will either send a typed response or answer your question live. You all as attendees can also upvote and comment on open questions if you wish. We will only have this hour and a half together, so we encourage that you all to monitor the question and answer pod and virtually engage with each other this way. The next is going to be the chat box. You can communicate with all panelists and or attendees at any time during the session. You can do so. You can also let us know if there's any issues going on. For questions, we encourage that you go ahead and utilize the Q&A. So for anything aside from questions, you can use the chat box. For questions, we prefer that you go ahead and use the Q&A section. And the last thing is going to be the raise your hand feature. If you have any questions during the Q&A live set portion, towards the end of the presentation, you can click your raise hand and the moderators will do their best to go ahead and open up your mic and to allow you to go ahead and express that concern or that question that you might have. And if at any moment you feel that you need to go ahead and leave the presentation, it's just a matter of clicking the leave meeting and that should be it. We will be recording, or this presentation is being recorded, so we will be making it available to you guys as well after everything is completed. So the following here is the list of NTAP faculty members and presenters that are here with me today. We will be presenting each other as we go into our portions. The learning objectives for this webinar is going to be the first one, to identify enabling services, workforce providers for social determinants of health screening of special and vulnerable populations at health centers. Our next objective is going to be to show the value of enabling servicing staff and how they can impact clinical and non-clinical decision-making at the health centers. And the last one is going to be to demonstrate the impact of analyzing social determinants of health screening data and increasing internal and external capacity to address patient social needs. The agenda for today is going to be as following. We're going to do the introduction. We will be showing previous webinars and reports. We're going to go ahead and highlight learning collaboratives. Each NTAP will go ahead and do a portion of their section, and then we'll go into questions and discussions at the end. So I would like to take this time to remind you guys that our Volume 1 and Volume 2 are out. Volume 1 explores strategies to screen for social determinants and build effective practices to begin addressing this through enabling services. And Volume 2 explores challenges to social determinants of health screening. As I mentioned, all of those are available. It's just a matter of going into the link that was provided in the chat box, and you can go ahead and view those. I would also like to take the time to remind you guys that this webinar is the kickoff for our learning collaborative. That is going to be taking place during August 9th. That's going to be the first session, but our applications are open only until Monday, August the 1st. So we would encourage you guys to go ahead and sign up for those learning collaboratives. As I mentioned, this is going to be a webinar that touches base on a little bit of the information. The learning collaboratives themselves will be the ones that have a little bit more content in them. And with that, we go ahead and start with our first objective, which is going to be identify enabling services, workforce providers for social determinants of health screening of special and vulnerable populations at health centers, and we have top health outreach partners who will go ahead and take this.
All right, thank you, Hansel. My name is Andrea Batiste, and I'm here with my colleague, Megan Urkel, and we are representing Health Outreach Partners in Oakland, California. Next slide. So enabling services, what are enabling services? They are non-clinical services that promote, support, and assist in the delivery of healthcare and facilitate access to quality patient care. Beneficial services like interpretation, transportation, care coordination, and health education. Provided by health centers to make accessing care possible for many of your patients, especially special and vulnerable populations. Enabling services are additionally important because they are integral in expanding access under healthcare reform. They help to reduce racial and ethnic disparities in health, and they are key components of quality care and value-based care. Next slide, please. As social interventions, enabling services help to address social determinants of health and their impacts on special and vulnerable populations, the ones that we serve in our communities. They often serve to bring patients in the door, but can also bring the care to the patients. In this role, enabling services provide patients with access to preventive care, thereby decreasing cost of care by improving health outcomes. In breaking down both common and personal barriers to care, enabling services are particularly important for those communities that experience the most acute health disparities in terms of access and outcomes. And in these current times and social climate, we can all speak to the value and importance of these services. Next slide, please. So the enabling services workforce providers, they include positions like case managers, outreach workers, transportation staff, and community health workers. Taking a look at the most recent data from 2020, overall from 2015, the enabling services workforce providers continued to rise and reached a peak in 2019 and went down a bit in 2020. The COVID-19 pandemic beginning in 2020 disrupted healthcare, ushering many services to increase their usage of telehealth. Reflecting in these staffing and utilization numbers, we see a decrease in utilization in 5 out of the 8 categories from 2019 to 2020. Provider categories whose services require direct contact with patients saw a decrease in utilization. You can see providers going down in categories such as transportation staff, while others like case managers have assumed even greater, more visible roles throughout the pandemic, being the principal contacts for patients and their families when addressing immediate and intermediate needs. Here, we can begin to understand the case for enabling services and value-based care. Next slide, please. The enabling services workforce is foundational to value-based care healthcare transformation. Value-based programs provide high-quality, accessible, affordable, and comprehensive healthcare, which aims to improve individual and population health outcomes while reducing costs in the long term. Value-based programs reward healthcare providers with incentive payments for the quality of care they give, using data and metrics to measure quality improvements and performance. Next slide. So under a traditional structure of payment for health services, many outreach activities and enabling services are non-reimbursable. However, over the past decade, there's been a national shift in the ways in which healthcare is delivered and reimbursed. For example, with the fee-for-service payment structure, this model is where the payer reimburses the provider for each billable service rendered. New service delivery systems and alternative payment models afford health centers the opportunity to provide patient-centered care in a more flexible manner, including the use of health outreach programs and enabling services provision and other delivery models. Outreach programs and staff can be leveraged to help fully understand and address the needs of underserved communities. Thus, Health centers will continue to have a key role in the identification of effective value-based care approaches that will meet the goals of the IHI's quadruple aim. Next slide. So the quadruple aim is an approach developed by the Institute for Healthcare Improvement, IHI, in order to optimize health system performance. The framework encompasses reducing costs, improving population health, and patient experience with a new fourth domain, healthcare team well-being. The idea is that without an improved clinical experience on the provider side, the three other patient-centric aspects won't reach their full potential. The quadruple aim brings the healthcare endeavor more full circle, making the practice of medicine a better experience for the patient and hopefully a better experience for the healthcare provider. By reorienting incentives to focus on patient value instead of volume, providers are rewarded for providing great care to their patients. Value-based care offers a way out. Oh my gosh, wow. So next slide, please. So now that I've shared, we'd like to hear from you all. We're going to engage this poll question. What types of value-based care models and payment are you providing or engaging with at your health center? And just feel free to click all that apply. And thank you. And now I would like to pass the mic to Megan Urkel once the poll closes.
Thanks, Andrea. And while you guys are filling out the poll, we can move on to the next slide. So I'll be talking a bit about social determinants of health and enabling services data. And data really is essential to population health initiatives and implementing value-based models. Several new advances have been assisting health centers in collecting data related to root causes of health outcomes, and really aiming to provide health centers with a better understanding of their patients' non-clinical needs. Next slide. So because enabling services data are inadequately funded and little is known about the impact they have on health outcomes, collecting enabling service data will highlight the value of them as an integral component of value-based healthcare. So HOP, in collaboration with APCHO and the National Healthcare for the Homeless Council, advocated for expanding the number of categories in order to fully reflect the types of services that health centers routinely provide. We successfully went from 8 to 15 major categories of enabling services listed here. These things include volume and length of time for all enabling services, setting of the service and encounter like face-to-face, telecommunication, offsite visits, etc., as well as language assistance. And we know that these 15 categories are not exhaustive, but they are what's necessary to align with UDS reporting. Next slide. So speaking of the Uniform Data System, back in 2019, they added 2 new questions in Appendix D around social determinants of health, including, does your health center collect data on individual patient social risk factors outside the data reported in the UDS? And if so, which standardized screener do you use? Next slide. So in 2020, we saw that about 70% of health centers reported that they collect data on individual patients' social risk factors, which is pretty similar to the previous year in 2019. And really 25% of health centers were in the planning stages in collecting this information. And the most common reasons reported for not collecting data around this include lack of funding for addressing these unmet social needs of patients, lack of training for staff to discuss these issues with patients, and inability to include with patient intake and clinical workflow. And we know that data collection to document SDOH and reimbursement for activities addressing can be challenging for health centers. And guidance is constantly changing. So to help health centers navigate these complexities. There are digital tools available that support SDOH and enabling services data collection, and that can help interface with the health system's electronic health records. These tools can pull in the correct Z codes and other documentation to ensure that this data is correctly collected and coded. There are several examples of enabling services data collection tools. You can see some of the most commonly used here in this table, and I will just briefly go over a couple tools that are most used. Next slide. Prepare, from the last slide, about over half of health centers reported using screeners used Prepare. It's an evidence-based national standardized patient risk assessment protocol designed to help health centers and other providers collect the data needed to assess and act on their patients' social determinants of health. You can see the core measures here on the right of the table. I won't get too much into it, but the great thing about Prepare is it's available for free to health centers, along with training and technical assistance on how to start using the tool. So I really encourage you after this presentation to click on this link here in this slide to get more information. Next slide. Another tool, the CMS Accountable Health Communities Health Related Social Needs Screening Tool. It's a mouthful, but just like with other clinical assessment tools, providers can use the results from this tool to inform patients' treatment plans and make referrals to community services. It can help providers find out patient needs in these 5 core domains that community services can help with, including housing instability, food insecurity, transportation problems, utility help needs, and interpersonal safety. And there are 8 supplementary domains included as well, you can see on the right of the table. Next slide. And just in closing, I'm not going to read everything on this slide, but it's just a couple recommendations we want to leave you with is we really encourage you to look at your state and health centers uniform data system information on payer mix and reimbursement history to identify opportunities to engage in value-based care, as well as talking to your leadership to see, is your health center using SDOH data? Do you use enabling services data collection tools such as Prepare, and what you are using this data for? Next slide, please. And we encourage you to consult your electronic health records again to see what SDOH data your health center collects and how the data is used. Next slide. And this last slide, just want to leave you here with a couple resources from health outreach partners if you're interested in learning more about value-based care and really to explore the impact. So we encourage you to take a look at these links, and I'll pass it back to Hansel. Thank you.
All right, thank you, Megan, for that. What I'm going to go ahead and do now is I'll go ahead and share the results of the poll that we went ahead and conducted. The question was, what types of value-based care models and or payment are you providing or engaging with at your health center? And we see here that 64% of you guys mentioned that we collect SDOH data on our patients. The next one is at 55%, we engage in population health activities. And at 51%, we have patient-centered medical home, PCMH. So those were our top 3 answers for our first poll. Thank you guys for participating on that. We will be having a few more polls throughout the presentation. So now we're going to go ahead and move on forward to objective 2. And objective 2 is basically, it is to show the value of enabling services staff and how they can impact clinical and non-clinical decision-making at health centers. So enabling services staff can have a powerful impact on communities and health outcomes while being cost-effective. We will demonstrate how using data supports the investment of dollars in enabling servicing staff. All right. So the impact of enabling servicing staff can be seen through the following 4 categories. The first category here is health outcomes. This measures a change in health, of health status of an individual or a group, which can be attributed to an intervention. So positive health outcomes would be things such as being alive, functioning well mentally, physically, and socially, and having a sense of well-being. Negative effects or negative health outcomes would be death, loss of function, and lack of well-being. The following is an example of how enabling services have had a positive outcome when it comes to health outcomes. So the Mississippi Delta Health Collaborate implemented the Clinical Community Health Worker Initiative to improve clinical outcomes for cardiovascular disease through aspirin use, HB1AC control, blood pressure control, cholesterol management, and smoking cessation in the 18-county Mississippi Delta region. This model was a success. The intervention of enabling servicing staff helped participants lower their blood pressure, control their cholesterol, and lower also their blood sugar levels. They also helped reduce their cardiovascular disease risks, and they also encouraged the individuals to be more physically active and stop smoking. The second and third category that we have here is service delivery and quality of care. Enabling servicing staff positively impact the delivery of service by ensuring that patients understand what is expected of them and allowing them to voice out any concerns. So this is going to be, in this situation, we see an increase in adherence to medication. We also see prevention of accidents due to miscommunication. The patient feels heard while the medical team has a greater understanding of the individual's situation needs. This in return also causes a positive effect in the quality of being experienced since there's communication and understanding between the medical care providers and the patients. CHW can help make healthcare systems more responsive by communicating information from the community back to the healthcare providers and vice versa through improving delivery and quality of care. And the fourth category that we have here is going to be the return on investment. We talked about how enabling services have a positive impact in health outcomes, service delivery, and quality of care, all which explain to us the change, but does not allow us to quantify it. This is where return on investment comes in. Return on investment is the money aspect of the impact enabling services staff have in health centers and other organizations. The definition of return on investment is a financial metric formula that compares the gain or loss from an investment related to its cost. It is useful in evaluating the return from an investment, program, or project. In fancier terms, it is the total value of benefit profit resulting from a program divided by the total program cost. So it's a very simple formula. If you go ahead and, it's a very simple concept, you can go ahead and look at the formula there. The first line shows you where the benefits go. So this is where the dollar value of the positive results, the profits from the profits after the expenses have been considered, that's where they go ahead and that's where they're placed in the first section. On the second line, that's where your expenses go, the cost of investment, the money that went into starting the program, staff, location, materials, etc. The difference between both is your return on investment. If you wanted to know the percentage, you would just multiply it by 100. So return on investment that is equal to 1 basically shows you that you break even. A return on investment score of more than 1 tells you that the program calculated benefits outweigh the cost. And a return on investment of less than 1 tells you that the program costs more than the calculated benefits it is producing. Now, a program who scores less than 1 doesn't necessarily make it an unsuccessful program. There are benefits we simply cannot quantify or might have missed. So return on investment allows us to put value on the work enabling servicing staff do so it can be included in your benefit profits. What do I mean by this? A patient who receives services from a CHW and learns how to better care for their health, which then results in lower medical costs for them for the rest of their life, is a foregone cost or unrealized cost. Money not spent that would have otherwise been used for that. So things that fall into this category would also be maybe reduction of emergency visits, the reduction of future medical costs due to early interventions or disease prevention, and also the reduction of expenditures for social or educational programs due to reduced drug abuse or early prenatal care. So these concepts need to go into your return on investment equation to make it more, to represent all the information and all the outcomes. Look for foregone costs or unrealized costs and see if you can quantify them to include them on your return on investment. Even if you cannot quantify the service, you can still use it to strengthen or support your return on investment analysis. An example of this is, let's say, by reducing unnecessary emergency visits, the patient and patient costs, this program saved X amount of money for every dollar of the program that the program cost. In additional, rates of depression, teen self-harm, and domestic violence declined by X amount percentage. So as you see here, you might not be able to quantify the information that you have when it comes to maybe the depression, teen self-harm, and domestic violence, but you can go ahead and utilize that information to support your analysis, to basically say, hey, you know what, this is how much money was saved, but this is the other type of impact that we are having, or that the program had in the community, to make it go ahead and to make it seem a little bit better. So it is important to know that there are various types of return on investment that tell us different things. Depending on who our audience is what we will be using. So there's three types of return on investment. The first one is the community level. And this is basically tells you how much benefit or return is the entire community receiving as a result of the investment. So an example of this can be preventing hospitalizations because patients, community members are following their care plans due to enabling servicing, outreach, case management, and follow-up. The other type of return on investment we have is institutional. And this is what return did the host clinic or the network receive based on their inputs. An example of this can be increased patient attendance to doctor's appointments due to enabling servicing staff reminders and follow-ups. And the final type of return on investment that we have here is the individual one. And this is what types of savings that the individual receive based on the inputs to their program. An example of this would be decreased out-of-pocket costs for diabetes care due to enabling servicing staff education, follow-up, and case management. So one CHW program can get three different types of return on investments: individual, community, and institution, to better show the benefits and how much and the type of impact the program has. So don't be afraid to ask what type of return on investment it is that you're trying to attain, or who your audience is, so you can go ahead and utilize the correct return on investment for that. All right, so why do we want to use return on investments? We want to go ahead and utilize return on investment because it's relatively easy to understand. As I showed you previously, the formula is pretty simple. You put your benefits minus your cost, and that gives you that return on investment. It is versatile. It can be individualized. It can be used for financial and non-financial components, like the cost of a doctor's visit and less sick days due to lower A1C levels. It also helps estimate direct financial impact. It also supports sustainability by showing how funding the program creates its own savings. And it is the basic estimate of profitability. So enabling servicing staff and other helping professions tend to think with their heart. That is a common quality of this helping professions, or basically a common quality of this helping professions is compassion. They see community need and they want to help as many people as possible. But many others think with their pockets, their wallets. Return on investment allows us to persuade those with a wallet mindset and show the worth of community health worker programs or enabling servicing staff programs. It also provides us with evidence for workforce development and increased recognition of enabling services professions. And it goes beyond the dollars and cents. A positive return on investment may indicate things such as an increase in productivity, efficiency, and improvements in quality and patient care. And before I finish my portion, I would like to go ahead and offer you guys some resources. The first resource that I have here is going to be the Return on Investment Educational Tool. This free toolkit was created for those that understand return on investment very clearly. And for those new to the concept, and or for those who are a little intimidated by it. The toolkit was designed to help you figure out the return investment of your community health worker program or enabling services staff unique to your organization. It provides pointers on building your return on investment team. It assists with figuring out the numbers to use. The return on investment is a great way to get to know your financial information, and it gives examples of return on investment calculation, and health centers have utilized all of this inside that tool. And it is bilingual. And it is free, just a matter of going into our website and downloading that. Another resource that I would like to go ahead and leave you guys behind would be, another thing I would like to mention is that MHP Salud also offers a collection of resources which provide guidance, information, and tips for organizations interested in starting or already invested in a community health worker program. Our work extends from single organizations assisting at every step of the way in planning and executing effectively CSW programs in their communities, all the way up to state and national initiatives focused on standardizing the CSW model and advancing the profession as a whole. So some of the topics that you can go ahead and find in our website in regards to the community health worker would be a CSW program readiness checklist. So it'll be a checklist that you can go ahead and do to see if your program, if your organization is ready to start a CSW program. And we also have a pre-hiring checklist. So things that for you to be on the lookout when you're trying to hire for a community health worker. And with that, we go ahead and go into our second poll. And our second poll says or asks, how many types of return on investment were presented today? So this is a little education to see if you guys were paying attention. And I'll be sharing that information with you guys as soon as we get those results. So I'll give it a few minutes for you guys to respond. And then I'll go ahead and share the answer with you guys. I do see here a question in regards to what I was mentioning. Can the Mississippi hypertension study just reference be attached? I will go ahead and include the link to that. I found that at the CDC website, so I'll make sure I include that in our follow-up email so you can go ahead and access that. So I believe we have enough time. I'm going to go ahead and share now the results for you guys. I believe it says the poll doesn't match the slides. Oh my goodness. That is true. I apologize about that. The poll does not match the slides. But either way, go ahead and mark the correct answer. And I'll be ending that poll now. Thank you for those that went ahead and participated. So I went ahead and asked how many types of return on investment we had. The majority of you guys at 73% answered 3. The next one was 5. The correct answer is 3. It is return on investment was a community level, institutional level, and individual level. So thank you for those that participated in our poll. And I remind you that we'll be having 2 more polls. So we hope you continue participating with us.
All right, so we'll just segue into the next learning objective, and this is to demonstrate the impact of analyzing the social determinants of health. And we'll actually be having 2 different sections here, and we'll start off with the impact of analyzing social determinants of health screening data and increasing internal capacity to address social needs. And if you haven't already met, again, I'm Albert Eisen Jr., Associate Director at AppShow, and I'm going to be joined by my colleague, Gabrielle Peñaranda. So we can go to the next slide, Hansel. All right, so this is just kind of the why here. Why is acting on the social determinants of health screening data important? It was really good to see in the first polling question that over 60% of you in this virtual room are collecting patient social needs. So for the rest of you that didn't indicate, this is a good kind of baseline to know that there are a lot of people out there in this country that are doing social needs screening, and it's only going to help kind of demonstrate your value to yourselves as healthcare providers. And for the community health centers here in the room, we know that Megan and Andrea talked about HRSA, or the Health Resources and Services Administration, the main funder for the community health center program. They are already trying to collect information on, for example, how many patients screened positive for food insecurity, for housing insecurity, financial strain, transportation, to name some of the few. But we know that there are plenty of more social determinants of health and social needs that could be collected in your electronic health record or other means, whether using paper or other modalities. And so at the end of the day, it's currently an optional requirement to report on this data to HRSA, but we know if we can predict with history, this might be required for HRSA and other funders out there in the future. And so it's easy now to get started while you're still kind of piloting your social needs screening data collection protocols. And really the next step and the most important step from what we've seen out there is to act on the data. So we know that patients who identify a positive screen for food or housing insecurity means that they are in need of something very important that can improve their health outcomes, as Hansel was suggesting in his previous presentation. And so at the end of the day, what does this do? It helps integrate our healthcare system with the social care system and can help reduce the total cost of care. And we know that the enabling services providers that many health centers employ are important and crucial to that work. So they might be the ones doing the social needs screening, but they also might be the ones doing the acting on the social needs screening data. And to name some of those workforce types, again, community health workers or the promotoras, as Hansel was talking about, have a huge return on investment if you really calculate how much they're able to save the healthcare system. And if you go back earlier to even Andrea and Megan's presentation, when they talked about the data from HRSA over time, you'll see that the community health worker workforce type has increased over time. And COVID has definitely helped increase that workforce because we know that the pandemic highlighted the need to address patient social needs outside of the clinical walls. And so at the end of the day, these bullet points on your left-hand side are just some of the reasons why we should continue social needs screening, but also acting on social needs screening. Next slide. And what are the kind of elements or ingredients for acting on data and responding to the data? If you peer into the Prepare Toolkit, as Megan and Andrea talked about earlier, there's a lot of resources in there on how to start your social needs screening process. And the later chapters in the toolkit talk about acting on the data. And so these are the three main areas that we talk about: people, processes, and technology. And I'll start with the left-hand side here with people. These questions here are just kind of the rhetorical questions to ask yourselves if you're still in that kind of planning phase. Do you have staff that can be dedicated to the social determinants of health initiatives at your organization? And below that is one example. Are there specific roles, right? Community health workers who are focused on addressing and social needs screening is one of those main roles that I've seen community health workers play a huge part, and also on acting on the data that they collect. But we have to talk about the process, right? How are they collecting this data? We know that electronic health records is one avenue, but we still see some health centers doing it by paper, especially if you're out in the field doing outreach and doing health fairs. You might be doing this manually, which requires really a process to put back the data into your electronic health record. And so you need people that are data savvy, that love data, and are able to kind of look at that data on the back end and to create reports. And so that's where all those population health tools come in and your EHR tools come in to really analyze that data. And there's some really good, again, tools that visualize it in a good way. That way your enabling services providers have a good sense of how they're doing with social needs screening. And they're able to see, for example, the top 3 social needs that are occurring in their patient populations. And, I will say that for the national trends out there, we're really seeing that food, housing, transportation, as some examples, are coming up as really top social needs for many of the health center patients that we're seeing. And what does that mean? That means creating resources in-house if you don't already have resources, and we'll talk about some examples later on. And if you don't have resources in-house or the capacity to create in-house resources, then you start looking outside of your health center or your healthcare system and really partnering with social service providers, community-based organizations, et cetera, who can really support your work in a partnership approach. And then lastly, but not least, technology. We know there are so many tools out there, and it's really about using those tools effectively and efficiently for your own purposes. And so, you might have the EHR, but then there might be third-party platforms that you might be subscribing to help address social needs. And we'll, name a few there. There's the big Aunt Bertha's, the 211s, the Unite Us platforms. There are so many tools out there. It's really about finding the right fit for your organization. That way the tools are being utilized, and that way the data is being mapped to those different tools out there. And so I will just, again, do some little plug that if you don't have kind of the IT or health IT folks at your organization to really help analyze the data, get those people hired and onboarded and really looking at not just your clinical data, but your social needs data, because those are the people that are going to be giving you the reports and the meaningful trends that you can act on as, let's say, enabling services providers. And so that's just the processes, right? Let's go to the next slide, and I'll pass it on to my colleague, Gabrielle.
Thanks, Albert. So I'm Gabrielle Peñaranda, Program Manager of Training and Technical Assistance at APCHO. We'll jump right into this matrix, which is from Chapter 8 of the Prepare Toolkit, and it offers some recommendations for what to do after you've assessed your organization's current capacity. So after you assess your own resources, it's important to determine what resources exist in your community. Analyzing your setting in terms of the type and extent of resources in your organization and in your community will give you a sense of where to start in bolstering your capacity to address the SDOH needs of your patients. So here, the vertical axis represents your organization's internal resources, and the horizontal axis represents the amount of resources there are in your community. For example, you might identify that your organization has few or fewer resources to respond to your SDOH data, and that your community has limited resources to address your patients' needs. The bottom left quadrant may offer a starting point for capacity building. In this case, where you have few internal as well as few external resources, you can build capacity by raising awareness to strengthen staff, patient, and partner knowledge of social determinants. Each quadrant of this matrix also offers specific suggestions on how to build capacity for the people, processes, and technology categories that Albert was just talking about. If we move directly up along the organizational resource axis, those who locate themselves in the top left quadrant will have more internal resources, but local community resources might still be limited. This puts your organization in a good position to create in-house services. And we'll have an example on the next slide. If you have staff time, or if you have highly effective processes or workflows, you can develop services internally that meet your patients' needs, even though your community might not have the resources to do so. Or you might find yourself in the reverse position where your community has an abundance of resources, but your organization's internal resources are still developing. In the bottom right quadrant, you'll find that partnering with community-based organizations or even community leaders can help you act on your SDOH data, even though your organization's internal capacity is still growing. Finally, for those who have both many internal resources and many resources within your community, you can strengthen your capacity to act on SDOH data. You can do this by forming coalitions with community partners and advocating for policy and environmental changes. It is important to know that locating your organization in one of these four quadrants does not mean that you might not also locate your organization in a different quadrant at the same time. So for example, you might have ample community resources and your technology resources are great, but you're short on staff time, which would of course greatly hinder your capacity to implement your initiatives. Or there may be plenty of local community resources, but there are few or none that specifically address your patient's most pressing needs based on your data. On the next slide, I'll share a case study of a health center that had a higher internal capacity, and we'll talk about how they effectively implemented their SDOH screening practices. Let's go to the next slide. Thank you. So in this example, San Ysidro Health in California administered Prepare with 3 different target populations: patients with diabetes and/or hypertension, patients with behavioral health diagnosis, and care coordination enrollees. Care coordinators administer Prepare during outreach calls to schedule patients for appointments or during care coordination visits. Using Prepare, San Ysidro Health identified that transportation was the immediate concern among its patients. Acting on its data, San Ysidro Health was able to establish a partnership with 211 to integrate community partners into population health management. And because transportation was the most pressing need of its patients, it deployed mobile health clinics to communities that had difficulty accessing the clinic. Additionally, SYH developed neighborhood health days. After analyzing geographic areas where patients with transportation issues lived, SYH brought services to them via its mobile health clinic and invited patients on a shared block or an apartment complex to visit the mobile clinic during the days when it was in the neighborhood. So SYH did have some particularly effective strategies to achieve these results. So it was strategic about implementing Prepare and promoting its use among staff. It focused on the pre-primary care experience, and it diligently tracked next steps to close the referral loop. So based on the matrix from the previous slide, we can likely locate San Ysidro Health to be in the top left quadrant, where an organization may have many internal resources or a greater internal capacity to respond to its SDOH screening data, but there were few community resources to partner with. This put them in a good position to build in-house services like the mobile health clinic to respond to its patients' needs. Let's go to the next slide for another example. And those are some of its effective strategies. One more. Thank you. So here's another example of the impact of screening for SDOH and assessing your internal capacity. And this is found in a case study of a partnership between an Oregon Health Center and a local farm in Portland. After screening for SDOH data that included food insecurity, the Mid-County Health Center of Multnomah County found an urgent patient need for fresh food and veggies. Zenger Farms, a local urban farm that seeks to promote food justice, had an interest in community health. This alignment of interests actually led to a partnership. Zenger Farms delivered boxes of vegetables to the health clinic, which were picked up by 25 low-income families who otherwise did not have access or had difficulty accessing fresh produce. By screening for SDOH data, the Mid-County Health Center identified patients' need for access to fresh, healthy food. It, however, recognized after assessing its resources and its internal capacity that it had greater capacity to help its patients by partnering with Zenger Farms. There were, however, some challenges to this collaboration and the success of the program. There were few financial resources available to support the program. And the Mid-County Health Center had greater patient interest in the program than there were resources to support that need. And these limited resources included language services for its diverse population, staff time to oversee the project, and workflow processes to protect patient info during the partnership. So where do you think the Mid-County Health Center would be located on the matrix? Its most pressing patient need was access to fresh food and veggies, but it didn't have a garden on site, but Zenger Farms had pretty much exactly what it needed. So while the Mid-County Health Center had fewer internal resources, it was able to identify a community organization that was a great fit to address its patients' needs. Later in the presentation, we'll learn more from Lauren about external capacity and forming partnerships. But keeping these two examples in mind as potential inspiration for your organization, let's return to assessing your internal capacity and the resources in your community through a poll. So in your current state, we're curious to know, in your current state, where do you identify your organization within the in-house partnerships matrix to address patient social needs? And remember, you can occupy different quadrants at the same time, but when you think briefly right now about where your organization currently is, do you find that you have few internal resources, few local community resources, many internal but few local community resources, few internal but many local community resources, or do you have many internal resources and many local resources? Based on the poll right now, it seems like there's quite an even spread. Quite a few have, yeah, it seems to be quite even overall. The majority of respondents now seem to have fewer internal resources and few local community resources. So like I mentioned before, starting at that bottom left quadrant of the matrix will be a good place to start when you're looking for recommendations for how to build internal capacity. Yeah, it looks like most of the respondents so far are in that bottom left quadrant. So thank you for your responses. Hopefully hopefully identifying your organization within the matrix will be a good starting point for you to build or even strengthen your internal capacity to act on your SDOH data. Let's move on to the next slide for some key takeaways. So as you plan to build your internal capacity, here are some things that you can remember moving forward. One, start with the data. So ask yourself what social risk factors were most prevalent when you screen your patient population. If there were a handful that came up, identify what resources are already available internally or externally to address these needs. Second, identify strategic opportunities. Are there well-resourced partners in your community who are looking to serve your patient populations, but don't have relationships or access points that your clinic offers to your patients? This is a good opportunity for a partnership, just like the examples mentioned previously. Third, let the needs of your population guide you. So just like San Ysidro Health and its mobile health clinic, you can use your organization's capacity to respond to SDOH data to meet the needs, to meet patients where they are, basically almost literally because of their mobile health clinic and with what they need. Finally, go where the resources are. Are you located in a rural area or a small town where resources are quite scarce? Consider reaching out to social service organizations in the closest city to you and see if they'd be willing to partner with you to serve your community. On the next slide, Albert will come back and talk a little bit more about some SDOH screening tools and resources.
Thanks, Gabrielle. So just want to highlight kind of two key resources that can really support your work moving forward if you haven't already accessed them. The first one on the left-hand side is the Protocol for Responding to Patients, Assets, Risks, and Experiences, or Prepare. This was, again, a co-partnership with NAC, the National Association of Community Health Centers, and the Oregon PCA. And we know it's built into different EHRs, and it's one of the most used standardized screening tools for health centers. So please reach out to the prepare@nac.org. I'll put in the email there if you have more questions on any training you need. And then the right-hand side is another toolkit that was co-developed by APSHO, Health Outreach Partners, and the National Healthcare for the Homeless Council. As Megan said earlier, this will help document your encounters by your enabling services provider type. So I mentioned in the chat box to somebody, why aren't we documenting the number of encounters by community health workers if they're valuable? Well, we know HRSA doesn't collect that type of data, but this toolkit will help you really tailor your EHRs and your templates to document the number of services you're providing, whether that's health education, transportation outreach, et cetera, et cetera. So this goes kind of further than what the DDS encounters, because we know that this data is valuable for your value-based payment contracts. So please take a look at these two resources on your own, and please email us if you have any more questions, and we'll pass it on to Lauren now.
Thank you so much. I'm Lauren Berner. I am a research manager at the National Healthcare for the Homeless Council, and I'm very excited to be with this wonderful group of humans today and have you all here with us. Next slide, Hansel. So I'm sure as we've been talking today, you've been thinking about the community that you work in and the people that you serve, and I'm sure there are some specific examples of how you're working to address SDOH that are already coming to mind. But I want you to just take a moment and pause and center a specific person that you work with as we're talking more about addressing social determinants. The example that I'm going to use is that of someone experiencing homelessness. Since we know that people experiencing homelessness really do intersect with every area of the social determinants of health. And when we envision a high quality of life and health for that person, we're really looking deeper than, again, some of those vital signs and looking at kind of even with primary care, how they access it and whether it's an appropriate use of services, whether or not they can afford that care, or there's delay in care, or utilizing the emergency room when things escalate, especially if they're not connected to a health center. And then when we consider behavioral health needs, we need to think about who is on our care team and make sure that substance use and mental health needs are being met. Is that something that that individual has access to and they need it? Do we have the expertise needed to address their concerns, including being trauma informed in our services? And how are we and our partners adopting harm reduction practices in our work? Then we start looking at some of the other considerations. So do they have access to safe, stable, affordable housing? And if they don't have housing, where are they going to store food or medication? Where are they going to seek shelter from weather? Is their sleeping situation safe, and will that protect them from potential traumatization? In the time of COVID, are they able to socially distance? Are they able to wash their hands? There are so many different aspects of housing that are really essential to our health. We've talked about transportation, and can folks actually get to appointments that they need to manage their health? If they don't have a car, can they even afford the bus, or is there even a bus route nearby that can get them to where they need to go? And if there is a bus line, can it get them there in a reasonable amount of time? Medications, which are often necessary to help get health conditions under control, may be too expensive. I'm sure we've all heard about folks delaying prescription refills or rationing medication due to cost. In some cases, storing that medication itself can be a major challenge. In the case of people experiencing homelessness, medications or syringes can be stolen, or they may not have access to refrigeration if they need to for something like insulin. Healthy food, again, we've talked a bit about this, but that is another important consideration. And many folks seen at health centers may not be able to afford some healthy food options, and they may live in food deserts or experience food apartheid, and they may not have the resources necessary to store or prepare those healthy options, especially when we're thinking about people experiencing homelessness. And the last piece I'll highlight here is safety. Not only is lack of safety traumatizing and has that biochemical stress response, but it really can keep people from being able to perform pro-health behaviors. Folks aren't going to want to exercise in a neighborhood that they don't feel safe in, or in an environment that they don't feel safe in. Next slide, please. I also wanted to just take a moment to think about how we frame social determinants of health as a piece of health equity. In the example, again, of people experiencing homelessness, we can really see how all of these social factors intersect with that person's experience to make an impact on their health. People experiencing homelessness are also disproportionately Black, Indigenous, or other people of color. So racial equity is important to this conversation as it is to health equity broadly. I apologize for my dog. We also see that 40% of youth experiencing homelessness identify as a member of the LGBTQ+ community. So that is also an important aspect of how we address social determinants for this population. To highlight a couple additional points here, we have several different domains that this can fall into. Again, lack of control over food, considerations around health literacy, and involvement with the justice system or experiences of discrimination, levels of educational attainment, and higher rates of extreme poverty, all of which have intergenerational impacts and structural precursors. So in all cases, having a trauma-informed and culturally humble approach are really essential to addressing the health and social needs of your patient population. Next slide, please. Thank you. And so we've talked a bit about what we need and a little bit about where to start. And Albert and Gabrielle talked about building capacity and considerations around working in-house versus developing partnerships. And I'm going to dig in more into the partnerships piece. So when we're considering who to partner with, it's important to start, again, with that screening that we're using to identify needs and gaps. Once you've done that, you can start getting really creative about who may be doing that type of work or who else may have the skills to do it. If the need is housing, maybe you want to get a representative of your team on the local continuum of care, which is the agency that distributes housing funds and places individuals into housing. Or maybe you want to work with a specific housing provider in your community to provide support services for those in their units. We've seen a lot of success partnering with farmers markets to address food insecurity. And we talked a little bit about farms, but some communities are working to host farmers markets specifically in areas that are experiencing food apartheid or providing extra benefits for those on SNAP. So one health center worked with their farmers market so that $10 in SNAP benefits can purchase $20 in food items at the market. Other communities distribute leftover produce after the market is closed to reduce food waste and help meet the needs of their community. One nurse that we talked with worked with their local shelter and soup kitchen just to rearrange the food as it was available on the bar. So the healthy food was on the front and people would fill up their plates with salad and vegetables before they got to some of the more carb or salt heavy options. They also worked to just encourage more healthy options to be available in general and really asking for specific donations to ensure they're nutritious. We see a lot of times folks donate leftover cakes or lots of breads to soup kitchens and food pantries. But we know that that can have negative impacts on folks who may be trying to manage diabetes or hypertension. Transportation, again, always a problem. We did see one health center in a smaller city that saw that there wasn't a bus route connecting to the neighborhood that many of their patients lived in and where they were and the services. So they worked with the city to add a bus line that would connect those folks with the health center and other resources. We've heard of rideshare programs or accessing transportation through insurance for those who may be insured through Medicaid or Medicare. Addressing safety, important to work with your community to develop maybe community development organizations. This can help to provide safe options for folks in the community and really start to replenish resources. Examples like if lighting or infrastructure challenges exist, it can be important to work with folks in your city planning office to help improve the physical conditions that folks are living into. And then partnering with the justice system is important. Small interactions with justice system can have a really big impact. And when we're thinking about people experiencing homelessness, one example of this is being ticketed for loitering, or in Tennessee, we have anti-camping ordinances that just went into effect. And not paying a ticket or not having a place to sleep can really create a larger issue if your ticket, again, goes unpaid and now you can't access other services, or if you end up with a misdemeanor or in Tennessee, in some cases, a felony for camping. That can really have a negative impact on your ability to access services in the future. So working with legal aid or the police department and creating diversion programs can make a really major shift in how your community addresses social needs on a larger scale. Health centers in Denver and Albuquerque are doing a lot of really great work in this area around diversion and sending social workers instead of police officers or in addition to police officers to connect people with housing and other services rather than having them be sent to the criminal justice system. So as you're thinking about this, it's really important to just get creative, especially for those of you who may not have all of the resources available in your community. Gabrielle mentioned that you could look at what's available in the next closest city, the next available space. Can we learn from COVID and offering telehealth and offer televisits for access to case management? Can we take that a step further and partner with those agencies and other communities to have resources set up here in your own space? Can you work with the food bank to have healthy food available in the library? Setting up transportation, working with your local school to use a school bus in the summer to get people into the city to access services. Get really creative with how you build these partnerships and what is available. Next slide. And there's a lot of different ways the partnerships can look. Again, lots of opportunity for creativity here. We often think about referrals, and maybe you're connecting folks directly to those resources. But how are you making them, and what does your relationship with that agency look like? And is there a way that you can find opportunities to follow up? We've heard from some communities that people aren't comfortable accepting referrals or asking for help. There's concerns with stigma. And so maybe there's an opportunity just to have that list, pull up the list of common things from Aunt Bertha and have a brochure somewhere in the lobby where folks can inconspicuously grab it. And that can be a way to make sure that people have access to what they need that also addresses their autonomy and how they want to receive it. And then there's also opportunities to work across sectors. So how are you continuing that communication? Again, is there a way that you can follow up on some of those referrals and maybe even reduce burden by having conversations with other folks who are working with that same individual? Can you work with the case manager to help document disability for somebody who needs access to housing? And can they help organize the transportation, take that off of you so that that individual can get to their healthcare appointment? Obviously, this would require consent from the patient, but it's really thinking about how we can take integrated care to that next level and incorporating social services. And then in some cases, you may be able to operate and offer services in the same space. So is there a room in your health center that maybe somebody doesn't use once a week and it can serve as an offsite office for a partner agency on that day? Or can you offer street medicine or mobile clinics, like the example earlier, at a prominent service site? And then full service integration is really taking kind of that concept of co-location and care coordination and thinking about what it would look like to have a care team that is multi-agency and multi-sector and just really, really kind of surrounding that individual. Next slide. So I just wanted to take a couple of minutes to talk about kind of some of the steps towards building some of these partnerships. And the first step of any partnership or program you want to start is to identify your goals and your consumers' goals, the goals of those you're serving. This can really help set the foundation for what your partnership can look like moving forward. And again, it's really important to start with the data that you already have and looking at that matrix that Gabrielle shared earlier. And once you have identified what your goals are, you can have an understanding of the value that you bring to potential partners and also the value that potential partners can bring to this relationship. Maybe one of you offers services the other isn't able to. Maybe there's access to a network or a population that you'd like to become more involved with as a health center. Maybe they have experience with a model of care that you want to implement. And there are tons of different ways that we can identify value in our partnerships. And then once you've determined the goals and the value, again, going back to assessing your capacity and your partner's capacity, being really critical and honest about what is feasible for you. There's nothing worse than biting off more than you can chew. And from a social work perspective, it's that under promise, over deliver, but really trying to understand kind of where are you at now so that we can set up a strong foundation of partnership. And then most successful partnerships do involve support and buy-in from leadership, since it is necessary to have those key decision makers on board early. Next slide, please. And then you've made the case, so now you actually have to make that partnership happen. And you can start by identifying partners that may already be in your existing network or considering organizations that serve your clients in other ways. And then when you're approaching partners, consider who the best stakeholders are, and maybe it makes sense to work with other service providers and think about what this would look like on the day-to-day, and then go get input from those higher up. Just depending on kind of what that relationship looks like to you. When you're approaching different partners, you may consider a one-on-one meeting, again, kind of service provider to service provider or administrator to administrator. Or you may want to have a multi-organizational meeting or have a community convening and get the voices of those that you're serving involved early. Or bring in third-party facilitation if you have the capacity to do that. And then think about the fit, services, and philosophy. And when you're selecting partners, really making sure that there is an alignment of organizational values, goals, and culture, and similar capacity to collaborate. Next slide, please. I just wanted to share this real quick, because when we think about partnerships, we often talk about it kind of as somebody is in a wheel and spoke model. When we want to surround this individual, we have some sort of connection to each other. But what we might want to consider is that full service integration, which is the next picture, if you click real quick, and thinking about moving beyond kind of that wheel and spoke and really having it be a plate of spaghetti. This was an image that a Learning Collaborative participant brought up a few years ago, and I just loved the idea of being able to surround somebody with services, and they don't even necessarily need to know where one starts and one ends. They just know that they are surrounded with what they need, and it is hearty and it is healthy. So next slide, please. I just wanted to know from you, what are some of the areas that you would want to engage external partners? And if you're putting other, I'd love to hear what some of those other partners might be. It looks like housing and transportation are kind of neck and neck for the top up here, followed closely by food. Right. It looks like we are slowing down. But yeah, housing, transportation, and food, again, kind of going back to what Albert said earlier about those being kind of the top 3 areas that we see as a need. Employment, technology being some of the others in the chat. Great. Thank you so much. All right. Stop sharing. All right, next slide, please. And as we are wrapping up, we mentioned at the top that we are going to be doing a learning collaborative on this topic. And one thing that we're going to be doing with that learning collaborative is having the opportunity to complete a change map. So this is just a tool that we'll be using to dive into thinking about how we can really start to address social determinants and act on that data in our own communities. Next slide, please. This is kind of what a blank change map looks like. You'll be provided with questions to answer, to reflect on kind of what your goals are, what your needs are, the steps that you would take as you're working through addressing social determinants of health. Once you answer those questions, they're broken down for you into different areas to consider, and your responses really do become actionable steps as you think about implementing something new or just adapting your practices towards your goal. Next slide, please. Wanted to just share a quick example of what this looks like when it's all filled out. So this is a completed change map from a previous Learning Collaborative participant and showing how their different responses get plugged in. You'll get a copy if you apply, which we hope you do, to the Learning Collaborative. You'll get a copy of your own change map and the responses so that you have a tangible outline, a tangible plan to take back to your community as you really start to dig into the work of acting on social determinants. Next slide, please. And if you fill all of that out, you will have drafted many, if not all, of the common components to funding proposals or grants. So if you're thinking about funding some of this work, you'll already have kind of an outline that you can use to get potential funders and potential partners on board as you start to implement this at your own site. Next slide, please. We will have a couple minutes to address some of the questions that have come up, but we hope that you'll take a couple of minutes to evaluate today's session while we do that. We really would love to hear from you. And again, please apply for the Learning Collaborative because we'd love to go deeper on all of these topics with you. If you have submitted an application already, we will send an email out shortly. I'm not sure if we've set a specific date for that, but they do close on Monday at the end of the day. So early next week. Thank you. Okay, please feel free to keep typing questions into the chat. We've had a couple that were answered in the chat already. I am happy to read those real quick. The first one that I found was from Susan. She asked if a CHW program is valuable, why does HRSA not count CHW as encounters in UDS? Albert answered that this is such a great question. We're glad you raised it. There have been various meetings with HRSA to modernize the data set to track encounter types and the number of encounters. It's a work in progress at the national level, so the hope is that we can document this in the near future. Did anyone else have anything to add to that answer?
Thanks, Lauren. Yeah, just to reinforce kind of the documentation protocol that APSHO, Health Outreach Partners, and NHCHE, that was a group of stakeholders, including health centers, who felt the need that documenting social needs and enabling services was both valuable to demonstrate value to a payer like HRSA. So take a look at that toolkit again. There's ways for you to work with your EHR vendors to customize the templates. We know that's sometimes a tricky conversation, but for example, I know NextGen is one of those EHRs that has been able to integrate enabling services encounters with social needs screening templates. And so I forget who mentioned it, but feel free to chat me privately and let me know if you have an EHR. I can see if there's any resources or technical assistance we can provide you offline.
All right, so one more time, we encourage you guys, if you have any questions, comments, or concerns, so this is scheduled to last all the way till 1:30, so we still have about 15 more minutes left. So if you have any questions, comments, or concerns, feel free to share those with us, and we'll be glad to go ahead and answer that. Okay, well, it seems, obviously, like I said, we still have a couple of minutes. So if you guys still have some questions, feel free to go ahead and drop that on the chat box. Feel free to unmute yourself, feel free to raise your hand. But we'll go ahead and share the following slide, the disclaimer, let you guys know that we are funded through HRSA. So we go ahead and wait a little more, see if we have more questions. Any questions, comments, concerns, things that might have stood out, something you want to share with another health center, another organization. And as a reminder, we have opened the application for our Learning Collaborative. So if you're interested in learning a little bit more of what we touched base today, we would greatly suggest that you go ahead and sign up to join that Learning Collaborative. It is scheduled to begin August 9th. So we do have the closing at August 1st. There's a possibility we might be pushing that, registration a little more, but to play it safe, go ahead and register by August 1st. Depending on how we see, we might give you guys a little bit more time, but as I said, the best thing to do is to register for August 1st. That way you'll be ready to go for when we start on August 9th. And it will be 4 different presentations that we have scheduled.
And you get a change map at the end.
There you go. And as Lauren went ahead and mentioned, if you're looking at doing your grants, this is a great way to go ahead and get that going, to get that information done. You get to learn, and at the same time, you get to work on that. And also, if you have any questions, you can always mention them. And who knows, maybe there's other health centers in our call that might be struggling with the same thing or might have struggled with that, and they can go ahead and shed some light to some of the problems. So I see here that we do have a question. It says, have you seen any examples of a combination of quantitative data and qualitative information from CHWs to think about SDOH? Sometimes data can have blind spots and we don't realize, and CHWs in particular come from the community and can provide good insight. I would like to add to that, that's basically what we were mentioning when we talked about return on investment. There are some blind spots, those unforgone costs, those unrealized costs, that if we're able to quantify, it would basically show the benefit of having that community health worker. If you're not able to quantify those numbers, you could always include them in your information as supportive information. So an example I had given you guys was where the health center had, they had shown X amount of money for every dollar that was invested. And then they mentioned that there was a decrease in depression, decrease in teenage, I believe, self-harm, and you basically utilize that information as supportive. So yeah, so there's moments when you won't be able to quantify that data, but always include it because even if you can't quantify it, you can go ahead and use it as something to enforce what you are already claiming. Does anybody else have something else to add to that?
Yeah, Hansel, I feel like with the recent COVID-19 monies from HRSA as an example, there's a lot of data coming out, both qualitative and quantitative, on their impact in terms of getting patients and community members in underserved areas to get screened, tested, and vaccinated, or just educated on how they can prevent COVID, as an example. And on top of that, we know that some health centers used their community health worker workforce to also do social needs screening in addition to doing the testing and vaccination. So I'll talk about some examples in like California and Texas where they did kind of co-testing. They did testing for HIV, they did testing for COVID, and then also ended up doing a social needs screening while you had that person in front of you. So really think creatively and efficiently about how you can leverage the enabling services or community health worker workforce and start documenting those numbers in terms of how many people you can committed to in those communities, not just patients, but community members as well, in like a health fair setting or an outreach setting. It really helps. And trying to find some resources. So if I do, I'll put it in the chat box.
And as Albert mentioned, a great place to go ahead and find those enabling servicing staff, community health workers is in your own community, going out through health fairs. A lot of the times these individuals are already volunteering. It's just a matter of finding them and bringing them, incorporating them into your own program, into your own organization. So we still have a couple of more minutes in case anybody has any other questions that you would like to ask. As I mentioned, any comments, anything that might have stood out, anything that maybe we didn't touch on that you would have been interested in learning more about. This is the perfect time to express those concerns. So we have your comment. I think it would be great to have an area near Prepare questions to be able to document not just community referrals offered, but maybe also community resources utilized in the past and not available to patients. We have another comment here. I would have liked to have been able to copy paste some of the chat list. Oh, we'll
copy and paste those into the follow-up email, right, Hansel?
Yes, sir. We'll be going through this to the chat itself, and any of the resources that were shared. We'll also include that on the follow-up email. We'll also include the slides. We'll include the recording and any other link that was shared to the presentation as well. Well, it seems that we don't have any other more questions. That means that you do have about 8 minutes left. So go ahead and take those 8 minutes and utilize them to go get a quick coffee, get yourself ready before your next meeting. But we appreciate that you took the time to join us today. And hopefully you will be signing up for a Learning Collaborative, and we'll be seeing you August 9th.